tratamento dos doentes com tumores EGFR positivos, mutados. Muito obrigada.
Thank you very much. Good morning. I'm sorry I don't speak Portuguese, so I will speak in English. So I've been asked to present the state of art for the EGFR mutant lung cancer first and second line treatment. It has been identified in about 10 to 12% of patients with non-small cell lung cancer that mutation in the EGFR gene will confer high sensitivity to tyrosine kinase inhibitor. The two most frequent mutations, maybe I can use this, are located in exon 19 and exon 21. There are other mutations that will also confer resistance, but as you see here, their frequency is much lower. We also know that mostly on exon 20, there are less frequent mutations, and these mutations are generally considered as resistant mutation. Actually, the mutation on exon 19 and exon 21 are driver mutation, and most of the so-called resistant mutation are gatekeeper mutation, and the resistance that they confer is not that clear, though. So if we look at the sensitivity to tyrosine kinase inhibitor, according to the type of mutation, you see here that for the classical exon 19 and 21 mutation, the response rate is high, median survival of about 8.5 months, and median overall survival of about 20 months. As compared to the wild type, where the response rate is much lower, the PFS is very short, and the overall survival, the usual 10 to 12 months. The so-called resistant mutation, when there is an insertion on exon 21, you see that there are absolutely no effect of the TKI, but the numbers are very low. We have other mutations. Some of them here, again, would confer some type of sensitivity and a better PFS and a slightly improved median survival. So where do we stand now when the use of TKI in first-line treatment for EGFR mutant? You know most of these trials looking at 3 drugs that are now approved by the European Medical Agency, gefitinib, erlotinib, and more recently, afatinib. Initially, trials were performed in patients without molecular biologic selection, but more clinical criteria. But when retrospectively or even prospectively looking at the patient with an EGFR sensitizing mutation, you see that those 3 drugs, gefitinib, erlotinib, and afatinib, provide a very constant median progression-free survival of around 10 months as compared to chemotherapy, where depending on the chemotherapy used, the range goes from 5 to, let's say, 7 months. The hazard ratio, where the drug was compared to chemotherapy, was very much in favor of the use of EGFR TKI in first line as compared to chemotherapy. But you see also here that there is no clear benefit on overall survival. As I will show you later, this is mostly due to a crossover in both ways. If you look at the available tyrosine kinase that we have now and that are approved by EMA, you see that their efficacy is very similar. This IFUM and URTAC were performed exclusively in Caucasian, whether the afatinib trial that are developed more recently mostly include Asian patients, so the comparison might not be always valid, but anyway, we are still in the range of a median progression-free survival of 10 months. The difference between those 3 TKIs is the tolerance profile. In Caucasian, in the IFUM study that I will detail later on, there was no grade 3-4 skin toxicity as compared to 13% in the URTAC trial and 16% in the afatinib LUX-LANG-3 trial. For diarrhea, we can consider that gefitinib and erlotinib are similar in terms of severe grade 3-4 diarrhea, and there is again an increase with afatinib. And another frequent symptom that patients report is asthenia. If we look at it, grade 3-4 was 0% in the IFUM study, 6% in the URTAC study, and 1.3% in the afatinib study. So in terms of efficacy, the three TKIs are very similar, but there are differences in terms of compliance that is important for quality of life. I will spend some time detailing the IFUM study because this is the latest study in Caucasian that was done at the request of the European Medical Agency, because when the drug gefitinib was approved, most of the data were generated in an Asian population. So patients were selected for EGFR sensitizing mutation, and if one of these mutations was present, they were treated in a single-arm study with gefitinib with objective response rate as a primary endpoint. And this primary endpoint showed that the response rate was exactly 69.8. It's easier to remember 70, 90% disease control rate, so very similar to what was actually observed in the Asian population. In terms of progression-free survival, again, 9.7 months, so the usual 10 months shown in most of the trials. And the overall survival at the time of analysis was 19.2 months, but since this was not the primary endpoint of the trial, there were still patients under treatment and under follow-up, and this real overall survival is probably slightly longer, but will never be reported. Interestingly, in that study, we also collected blood samples at the time of diagnosis, two samples of blood, and we tried to correlate the incidence of mutation within the tumor on the biopsy and on the plasma DNA. And you see that this is very interesting because we found in 13.7% of the tumor a sensitizing mutation that was found again in the circulating free DNA. So this shows that we may be able actually to test patients for which there is a tissue problem on circulating free DNA. The concordance rate was very good, 94.3%, specificity almost 100%. The weakest point is sensitivity, around 66%, but this might be due to the fact that this was done in a central lab and plasma had to be sent frozen to the central lab, and we know that it's kind of an issue because DNA may degrade faster during the travel time. But anyway, circulating free DNA may be a source to identify the mutation, and this has been reported in other studies, mostly from Asia. You see here that in tumor tissue for the exon 19 deletion, 60 tumors were identified both in the plasma and in the tumor, but again, there was a negative results in the plasma in 21%, which is roughly, in 21 cases, which is roughly 25%, and similar for the point mutation on exon 21. The sensitivity was a little better, again, specificity 100%, and positive predictive value 100%. So this might be the future for the identification of mutation, and we even have recent data on survival from the IMPRESS study, I think, that were reported by Tony Moak, and you see that again in those patients for which a mutation was identified in the circulating free DNA, there was a benefit on progression-free survival and overall survival. So those data were generated in first line. We, however, know that in patients with EGFR mutation, the EGFR TKI will work also in second line or even in third line. These are isolated reports from small series of patients, but you see that the response rate for the use of TKI in second or third line is in the range of what we have seen in patients with first line. And most of these patients were actually pre-treated with conventional chemotherapy. So you can still use the TKI in second and third line, but there are evidences that patients will benefit more if the TKI are used in first line. And this cartoon here from a publication in the Journal of Clinical Oncology showed that in patients with mutation, if you start here with a TKI, you will have a median progression-free survival of 10 months. Then at progression, most of the patients will switch with chemotherapy and will have about a 6-month median progression-free survival, and then they will go to best supportive care and finally die at an average of 24 months. It is also true if you use chemotherapy first. We know that with chemotherapy first, we have a median of 6 months progression-free survival. Then, as I have shown on the previous slide, if you switch to TKI, you will have the usual 10 months on progression-free survival. Then the patient may go to a best supportive care and die, and overall, the overall survival will be the same. However, some patients will not go to second line. And if you start with a TKI first, you will have the 10 months progression-free survival, then the 2 to 3 months best supportive care with a median overall survival of 13 months. And if you start with chemotherapy, you will you will have the 6 months progression-free survival. Then you may go to second line or best supportive care, and you will have again 2 and 3 months, and the median survival will be shorter. So it is important to know how many patients will not able to receive a second line, and this has been studied in a variety of trials. It is known that in most of the trial, patients treated with EGFR TKI will receive additional line. But if we look at the number in published data, we see that in patients who started with chemotherapy first, 30 to 40% will never receive a TKI because of either comorbidity, side effect, deteriorating performance status. This was 36% in IPAS, 41% in the Japanese trial, and 30% in the Chinese trial, Optimal. And there are reasons also to favor the use of TKI in first line because their mutational status may be altered by chemotherapy. We know that clonal selection under chemotherapy reduces the abundance of the EGFR mutation, and this is clearly correlated with efficacy. We know also that ERCC1 expression, which is potentially a marker of platinum efficacy in EGFR mutant, will increase sensitivity to platinum. And in studies where the EGFR mutation was looked initially and patient treated as neoadjuvant setting with TKI, the comparative study of those mutations before treatment and after TKI treatment show an altered mutation profile in the resected compared to the diagnostic biopsy. So there are indirect evidence that we should favor the TKI in first line. We don't have any direct comparison, but we have indirect data from Japanese study and the TORCH trial. This is the results of the Japanese trial WGTOG for patients who received both TKI and then chemotherapy. So you see that their median survival is about the same. But for the patient who started with a platinum doublet and were never able to receive a TKI, this is their overall survival. This is not significant because of the number of patients, which is low, but if you look at the median, the patient receiving a TKI first line followed by a platinum or TKI followed by chemotherapy without platinum, the median survival time is between 35 and 45 months. In the patient who received a platinum doublet only, this is only 13 months. And the results were very similar in the other Japanese studies where, again, very few patients, but the patient who never received a TKI did poorly as compared to the one who received both TKI and the chemotherapy. This is also true with erlotinib in the Optimal trial in China. This is a survival curve of patients who receive a TKI, and this is the outcome in patients not receiving a TKI. Again, a median survival of above 30 months compared to the usual 12 months. So we have lots of evidences that TKI should preferably be used in first line. There are also some statistical tools to evaluate the impact of the crossover. And one of the most often used is the IPCW, standing for intermediate proportional censoring weighting. And you see that in the IPAS study, if the patient had not crossed over to TKI, they would have a median survival of 14 months and around 21 months if they received both. So clearly, the crossover has an impact in the result of those studies. Now, as you know, most of these patients will recur, and we have to identify resistance in terms of primary resistance and acquired mutation. It is important also to take under consideration that when you discontinue the TKI, there is a risk of a flare effect, which is an accelerated disease progression, quite often associated with death. And this occurs in patients with a short PFS on TKI, mostly patients with pleural and CNS metastasis. And the recommendation to avoid the flare is to keep the TKI until you start chemotherapy without the usual washout period. This is an illustration here of a patient when he finished his treatment with TKI, and 3 weeks after, there was quite an explosion of tumors, and when he restarted TKI again, he responded. So in terms of primary resistance, we have to identify primary resistance. Those are patients who have no clinical benefit at all from the TKI and with a progressive disease or stabilization only within 3 months. To the opposite, the acquired resistance published by Jackman occur when there is a clinical benefit under treatment with an objective response in most of the cases. There is a document progression under treatment, and of course, no systemic treatment has been used in between. The resistance is, most of the cases, associated with the appearance of the T790M mutation and some less frequent other possibilities. And we have new drugs now. There are many drugs under development that can counteract the effect of this T790M mutation. One is AZD9291 from AstraZeneca, where they run a phase 1 trial including patients with T790M mutation. And in this series, first of all, the tolerance was good because those new drugs more or less spare the EGFR wild-type receptor, and the toxicity profile is much better. And this is the outcome on these patients who were pre-treated with TKI, developed a T790M mutation for most of them. You see that there was still a high incidence of response. Similarly, the Clovis company has the CO1686. This was the initial patient population for phase 1, and these are very fresh data that were presented yesterday at the ELCLC meeting in Geneva. You see on a larger number of patients, an extended cohort, they have a response rate of 64%, a PFS above 6 months in patients who were pre-treated with TKI. So there is a hope to counteract this mutation. And this is the present survival data. So non-small cell lung cancer is a good example of personalized medicine. Most of the target right now, or the drug now, will target the EGFR pathway. There are other pathways for which we don't have drugs except crizotinib, of course, in ALK translocation. There are many new drugs under investigation, and the question will be to identify the mechanism of resistance when it occurs. You have seen that in 60%, it's a T790M mutation, but there are remaining 40% of patients where it could be HER2, MET amplification, or combined modalities. Thank you for your attention.